Good morning, ladies and gentlemen, dear colleagues. I'm very grateful for this more than kind introduction Dr. Jonathan Schofield just made. And this recalls me many years ago when the late John Maclean, which probably still, everybody knows who he was, he got an award in America. And then there was also introductions, but it was not only one person, I think 3 in a row gave an introduction to him. And when he went to the podium, he said, after this introduction, I can hardly wait to hear me speaking. And so that's really his sense of humor was absolutely fantastic. So I feel deeply privileged and honored to be here and to share a little bit of our activity in the field of implant aesthetics with you today. As you have heard, in Switzerland, you have to retire at 65 at the university. It is official, they kick you out at 65. And, but luckily, my friend, for many years when we worked together with Professor Daniel Buser at the University of Bern, he managed to get me a guest professorship part-time. And this created a little bit of problem at the University of Bern because suddenly the professors from other faculty said, well, if you can have somebody beyond 65, we would like to stay longer also. And then the president had a problem of the university, but then he said, well, he came from outside. If you manage to get a professorship on another university when you are retiring from Bern, then you can do that. And so this closed this discussion. So I'm very happy also that I can still work a little bit. I go 1 day per week to Bern, which is very, very close to Geneva. And I treat almost the whole day patients of Professor Buser. He's a surgeon and I do the restorative work. So I can show you quite some new material, what have been done recently at the University of Bern. And usually I'm proud to say that I'm coming from Switzerland, but when I think what the headlines showed yesterday about FIFA, not so brilliant, huh? Not so brilliant. I hope Switzerland's reputation will not get too much damage out of that, but it looks quite messy. Okay, now this is the program, and of course everybody wants to discuss today aesthetic issues, and this is only part of the whole thing, and I will quite often implement this, that we should not do things only for aesthetic reasons. If it's in the visible zone, we try to do it as good as possible to please the patients, but we try also to still stick to the mission, to the general mission which dental medicine has. We are dental doctors, and we should not forget that when we are discussing aesthetics. I would like to start with a picture from Geneva. This is the town I'm living now since 30 years. I don't know if you had a chance to visit. It's very small, actually only 360,000 people in the whole surrounding. The city itself has only 165,000 people, and it has probably an oversized reputation due to the fact that there are some of the international organizations in Geneva, like the Red Cross, the International Committee of the Red Cross, the World Health Organization, and it's also one of the headquarters of United Nations. And you see these buildings are over there in this area. And in summer it's quite pleasant, and we have been proud for many, many years about this water fountain, Le Jet d'eau, because it was the highest water fountain of the world, 130 meters. And as you know, probably recently in Dubai, they made a fountain, because we have been told that this is technically the maximum which is possible, and it was kept very secret, the tubing, and they had doubled it in Dubai. I don't know how they did, but so Geneva has unfortunately no more world records, but it's still pleasant in summer, and we have very distinct seasons. 3 years ago, there was overnight a blizzard in winter, and I like to show this picture because ice is also part of the family of ceramics. Brittle material, and of course these car owners had to wait, I think more than 1 week to let it melt, and the cars survived without problems, and also the plants. So quite often we have this kind of weather also in winter. And if you have a chance once to visit Geneva, I would recommend that you would go for maybe 2 hours to the museum of the Red Cross. It's something really emotional, and it shows the whole history, how it's been created, and it's really something which is worth visiting. So if you once have a chance to come to Geneva, go to that Red Cross Museum. It is really something particularly well done. As Dr. Schofield has said, I'm working now part-time as a guest professor at the University of Bern. This is my colleagues, which I work with. This is Danny Buser, and this is Anton Skoulean, the head of periodontics. And we make quite often master classes also. And by this token, I would like to remind you that if you send me an email just to info@ccde.ch, you will get automatically the PDF of today's lecture, integral. And of course, you will get also a little bit publicity of the CCDE, which is the Center of Continuing Dental Education at the University of Bern, where you see the different programs which are offered. That's why. So you don't need to write any text, just an email and saying Belser Bristol, and you will get the handouts, the PDF file, by email. This is the program of the day. I would like to start with a rather large introduction and scope to really try to define the topic, what I would like to share with you today. Then, quite briefly, review a little bit the current scientific documentation of that field based on clinical studies, and then spend most of the day on clinical and laboratory procedures and in form of case presentations. And then later on in the afternoon, we will address then implant fixed dental prosthesis in more extended edentulous areas of the anterior maxilla, and end the day with the management of aesthetic implant complications, because we see a lot of complications, and I will try to explain why we see so many complications and what our possibilities are to prevent and to treat if it happens. And then come up at the end to some conclusions and perspectives. We have agreed with Dr. Schofield that at the end of the second presentation today, just before the lunch break, we will have question and answers. If you have questions, I will stop precisely at 10:30 for coffee break, and I will really stick to the program so that we will have then the second session from 11 till 12:30, and then it's lunch. Okay. Whatever we do in clinical dentistry, and particularly in implant dentistry, the main objective will be to promote and maintain healthy peri-implant tissues. And I know that we will primarily discuss aesthetics today, anterior region, but I like this picture a lot to remind you that in the posterior part of the mouth, we have different protocols, very simple protocols, and it's just an example how we can maintain healthy peri-implant tissues if we are staying with prosthodontic interfaces out of the tissue. Don't forget that. That is still about 75% of our activity when we are using implants. In the posterior part, where we try to keep it really simple, this is not the topic of today, but I just would like to remind you. In the anterior part, it's obvious that we would like to fulfill the patient's expectations, that we don't want to display any metal, but it is not many pictures I can show you like these, where you see on the right-hand screen, where you see really healthy peri-implant tissue, although the interface is submucosally located. Usually it looks quite different, and I will show you and allude to that during the day. Here you see every single capillary. It's really unusual to have a view like this. I don't know how it is in your hands, but it is not so easy to stick to that principle to promote and maintain healthy peri-implant tissues. But we will only be successful if we achieve this. Implant aesthetics. Here you have a young patient congenitally missing lateral incisors, and we see also that because the adjacent natural teeth were peg-shaped, that the clinician had a little bit modified and compensated this lack of volume with some composite restorations. And the patient was wearing, until she has now reached the age of 23, a removable partial denture. And when we look what we have in the literature of how an anterior dentition should look like, I'm alluding to this aesthetic checklist, which we have published when I was in Zurich in 79. It's a long time ago. We revisited with Pascal Magne in 2002. But this is just summarizing 14 parameters which we believe are objective and will contribute to aesthetic appearance of an anterior dentition. And we have now the theory on the right hand and the clinical case on the left. And we can imagine quite a lot of things, how this patient should look at the end. How do we communicate with the patient like this? So that we are not pushing the patient to over-treatment. Because if you want to reestablish perfect harmony, then eventually we should also do something on the adjacent natural teeth. But maybe this patient is not interested in that. So how do we communicate? Which is the word which I would like to hear now? Mock-up. Try whenever possible to show the patient what is the treatment objective without doing any irreversible steps first. That's not always possible, but here it is. We take alternate impressions, mount it in an articulator, and the technician will first just wax in 2 ideal lateral incisors and provides a very well-fitting key so that I can press acrylic in the next session in this situation. And then he continues. He modifies also the centrals and the canines according to optimum aesthetics and gives me a second silicon key. And I will, in the same session, press with acrylic. I usually use ProTemp on this dentition, and the patient stands up, goes to the mirror, and compares. And then if the patient says, well, not a big difference, then I know I will just place the 2 implants and do the restorations. Or we do what we have done here. We did also some very conservative adhesive restorations on the centrals and on the canines. But we did not push the patient to over-treatment. The patient could decide together with us if, and she was very interested. I mean, it's never perfect, but it is nice. Huh? I hope you agree that this is a more global aesthetic integration now, and if this stays long-term like this, then I think we have a very happy patient. But the patient could decide before we did any irreversible steps. Of course, we were using implants, but we were also using what we call today contact lens veneers on the centrals and on the canines. When we look at this checklist of the 14 items, what you see in red is probably the most relevant when it comes to anterior implant restorations. It is very difficult to achieve what nature normally does, interdental closure, that in a young, healthy dentition, usually there are no open embrasures, no black triangles. That is not so easy because when we lose a tooth, place implants, we almost always lose some soft tissue, normally about 2 millimeters. And we have to compensate this loss with the restoration itself and still try to keep what you see as number 4 here, the line of emergence should still be triangular as we see it on the natural dentition, so that the highest point of emergence is still distal of the tooth long axis. And then try still to maintain at least the illusion of harmonious or balanced relative tooth dimensions. That means length to width ratios. That is probably the most challenging when we do implant restorations in the aesthetic zone. I cannot show you hundreds of so nice examples as this one here, where the illusion is almost perfect. We have no open embrasures, we have harmoniously scalloped soft tissue contours and balanced relative tooth dimensions. As Garber said many years ago, we succeeded in making the artificial look natural. And it's quite striking that on two bases which are so different, what emerges from the soft tissue looks very similar. And that's not always the case. And this is a patient we treated almost 20 years ago. And when I saw that, when I took that picture at that time, it looked really like a periodontal pocket to me, what you see on the implant side. Today we know that this is the normal adaptation of the biology to this kind of a component which we insert, which is an implant. And I will try to demonstrate what it needs that we are able to keep soft tissue and bone stability on anterior implants. I got directives from the two directors here, Dr. Jonathan Schofield and Timothy Harris. They said that they would like me to present the evidence and cautiously derive clinical recommendations. It's a nice principle. I want to stick to that. I would like really to bridge the gap between science and clinical practice today. And I think this is a long tradition of the ITI, and I would like to stick to that as much as possible. Here you see the hierarchy of scientific, of evidence. This is based on the publications of evidence-based dental medicine, or medicine, of course. And England has been instrumental in developing these principles. And you see on the top of the hierarchy, we have systematic reviews based on randomized controlled trials. And then the gold standard still for clinical studies would be randomized controlled trials, and then goes down. We have a lot of case series. If a case series is correctly designed and performed, it's still a very valid instrument of testing novel treatment modalities. And then we have a lot in the literature on case reports, particularly in the field of reconstructive dental medicine, and we have a lot of experts. Here you see one. And you see, I'm on the bottom of the hierarchy. And what you see here is, and what you hear from me is more eminence-based than evidence-based. And I still remember when I was a student, the professors in Zurich said, you have to do it like I tell you, because I know this is the best. And we had to accept it because we wanted to get our diploma. But today, students have changed their attitude. They say, well, professor, it's nice what you show us, but prove us, please. And we have now a growing body of scientific evidence for many things we are doing that we can say this is really, for the time being, the documentation, what we have for this and or another protocol. I don't want to dwell too long on that, but have you ever asked yourself why the life expectancy of men is inferior to that of women? This is published every year in all of the countries, the statistics, it's several years difference. Do you have any politically correct hypothesis why this is like that? Are we working harder, being more stressed? We can think about many things, but what about this? If there is a direct relation between that. So what you see here is just one anecdotal example. Is a procedure we done on a patient and it worked. Do we already have a concept? No, it's just an anecdotal thing that eventually there is something. But what about if there is a second one? Confirming. We did the procedure a second time and it worked. And we feel much more comfortable already and think, yes, I do it all the time like this. I have one, the most brutal one is from Paris, which confirms it again. Now we have really done it 3 times and it is always working. And the last one I can show you is this one here. Always the same line. And it is not this kind of evidence we would like to present today. So we would like really to have more solid data when we are promoting, or particularly when we want to recommend novel, easier treatment modalities for our patients. And I would like to start with one publication which has been performed at the Department of Oral Surgery at the University of Bern. They just made 2 times, once published in 2008 and one this year. They just looked all the implant surgeries which had been performed in this department. And they wanted to know how many patients and how many implants per patient were placed, the age, indications, locations, and the type of surgery. And I would like just to highlight a few things. Here you see the darker histograms are the first study, and then the lighter one, the more recent. And you see here, when it comes to the age distribution of patients, that the mean age is around 53 years. That is where we placed most implants, and this is probably the same also in most of the countries. What does that mean for us? We have a very predictable treatment modality. And so we can say today that the goal should be that we have a therapy which lasts for 30 plus years. And implant dentistry is probably one of the rare modalities where we can really assume that. Not necessarily when it comes to the restorations, I will come back to that, but the implants, if it's well planned, well performed, they will probably stay in the patient's mouth for very long. And that means that we have to have protocols which are in this line. And that is what implant dentistry really can offer. Here you have the dental chart. You see from upper right to upper left and the mandible, you see all the teeth. Where do you think we place most often implants? It's here. That is indication number 1. Very clearly at University of Bern on both studies, it is the replacement of the first mandibular molar. That seems to be a tooth which, for different reasons, will get lost first. And so we have to have a protocol which is particularly addressing this indication. and we will not talk about this today, but that's where we do a lot of single-tooth implants just in between two natural teeth. Surprisingly, the second most indication is the central incisors. That has to do a lot with accidents and also with endodontic failures in this area, because these are teeth which are particularly exposed. So we have to have also predictable protocols specifically addressing this indication. And the third most frequent indications is the replacement of missing maxillary premolars and first molars. So there is where the most need for implant dentistry is. And so we should think now if with the same protocol we can satisfy all these indications, or if we should be a little bit more specific when we are addressing this. Today, approximately 95% of our implant patients are partially edentulous, not fully edentulous. We started with fully edentulous patients in the 80s, but now most of the activity, and you see the single tooth gap. That means an implant in between two natural teeth is more than 50% of our indications. That's where we traditionally make conventional bridge work. So a lot of this has disappeared due to the fact that we have such a predictable predicament. Then you see the distal extension sites are 20%, more extended edentulous areas where multiple teeth are replaced is 20%, and edentulous is roughly 5%. That at least reflects what this department of oral surgery has performed during the recent years. When it comes to the surgical procedures, it's very interesting also. You see that there is a clear trend to more complex surgeries. In the first study, roughly 48 or 50% were implants placed without grafting but opening a flap. This has been significantly reduced, so it's only 38% in the latest survey. Implants without grafting, flapless, had not been done during the first period, and we see roughly 1.5%. So very, very few implants. This would be typically tooth out and implant in the same session without elevating a flap. Only 1.5%. Of course, this is a specialty clinic which lives from referrals from private practice. So maybe this is not exactly reflecting the real world, but it is still giving us a lot of information. Implants with guided bone regeneration or grafting is roughly 42%. And implants with sinus floor elevation, 17%. And when we sum it up on the bottom here, you see that implants with GBR or sinus floor elevation make roughly 60% of what we are doing here. And so we should be prepared to have protocols which help us to be very predictable performing when it comes to these parameters. While we are still at the beginning of the presentation, let me repeat something which is not new at all, but which is probably the most significant slide I'm going to show you today. Whatever we do when we have a patient with a problem is we should only do things which we are sure are promoting long-lasting oral function. That's the ultimate goal. And this will include aesthetics when we are in the visible zone. Do you agree with that? That has been always the case. Only do things which will prolong the oral function. Now, the decision-making parameters which we would love to base to use as a basis for our treatment plan is we would like only to do things which we know they work, to solve that problem which we have identified in the patient's mouth. Predictability. I don't want to bore you, but we always should think, do I do something which is predictable? It will do the job. Secondly, I would like to be as conservative as possible. Minimal invasiveness. And we have today so many treatment modalities which permit us to be very conservative. In the past, maybe 30, 40 years ago, we had only one tool in reconstructive dentistry. This was the diamond burr. Huh? And we tried to solve everything with our burr. Today, we have, luckily, much more attractive treatment modalities. When you just think about adhesive dentistry, which we always say, well, this will never work, dentin bonding will never work. Today, it's there. And it helps us so much to be less invasive. We would like to have minimum risk for our patients and for ourselves. And ideally, we would like also to be efficient when it comes to time and money. That is what the patient would expect, that we best defend his budget also, and time-wise. You agree with this decision-making, and nobody can be against that. It's not so easy to put them in a treatment plan all together, all the time. But that's what we ideally would like to have. And I left one slot open here for a fifth decision-making criteria, which I think is very important when we talk about implants, because they will stay for so long. So, ease of reintervention. We should think that even if you're convinced that we do it right, that sometimes things go wrong. And then we should always try. Does my treatment plan also permit eventually a reintervention without being too complicated or without destroying everything I've done? Many years ago, I was asked myself, why does the English language need 3 words to say the same thing? And you are much more competent than me in English language. Efficacy, effectiveness, efficiency. When you go to the dictionary, that's why I put it like this, efficacy and effectiveness is different than efficiency. I'm not going into detail, but these 3 words are very instrumental when it comes to a treatment plan. Because, and here you see the hierarchy, the most important is to make the right choice. We have a problem in a patient. This can be a caries, a missing tooth, a malposition, whatever. And we have to ask ourselves, which tool is the best and the most predictable, least invasive, least risky, least expensive to solve that problem? And that is to do the right thing. Once we have decided this, execution has to be correct. That means to do the thing right. When I look back to what I've done during my clinical activity, I think I have quite often made a correct execution, but I had made the wrong choice. That's why I'm insisting so much. When you see your own failures coming back, then maybe we have tendency not to be affected by failures or complications produced by other colleagues. If it's ourselves, then it affects us. Then we think, well, I really wanted to do a good job, and now look, this is happening. So that's why today, because we have so many modalities, we need a little bit more time at the beginning to think if I have made or if I make the right choice. And then thirdly, to do it economically, that is clear. We want to save time and money, and this is for the graduate students. When I look a little bit, when case presentations are done in the specialty programs, I sometimes see fantastic final results. but the patient came 42 times to get there. And this has then no relevance when it comes to a real world. We should also think that, can I reach the goal in the minimum sessions and with a minimum amount of costs? Then if we can stick to that hierarchy, follow the principles, and do it as you see here, then we are perfect clinicians. That was just what I wanted to say. That's the most important. Because we are quite often today confronted with novelties. You know, you go to the IDS and you see so many new scanners and material that we should not forget that this still is the most important. The patient will expect from us that we do the right choice for him and that we are knowledgeable to know and that we should not forget. And this is what has a huge documentation. Professor Buser, when he shows this slide, he says always, look, this is well studied in preclinical, animal studies, and in clinical studies. And he says, stay away from cowboy techniques, from shooting from the hip. This is what predictably works. That means an implant placed slightly more to the palate. He says it's the palate bone wall which is the most important for anterior implant surgery. Use a slightly inferior with dimension implant than the tooth which had been there. He always places autogenous bone grafts directly in contact with the exposed implant surface. He always goes for a two-wall defect. I will show this later. And these bone chips are harvested in the environment. And then he covers it with a bone filler which is low substitution. And it will be surrounded and embedded rapidly by newly formed bone and then covered with a membrane and primary wound closure. That is what has a huge documentation. I do not say that you cannot achieve the goal with something simpler, but you have to be good and you have to select the cases where you can do it. Tooth out and flapless and in, it needs optimal preoperative conditions. And in most cases, we don't have them. Professor Buser, at the maximum, uses 10% of anterior implants, flapless and immediate. All the rest is done in this way here. And it has also some shortcomings. There's no doubt about that. Because we don't want to see this happening anymore. I mentioned this yesterday. 25 years ago, osseointegration was considered a miracle. If the implant was integrated, then we were happy and we told the patient, it is integrated. And then the patient and the clinician thought, well, if it doesn't look so well, at least we did not touch the adjacent teeth and you have, but from today's perspective, this is unacceptable. A young patient, she's in her mid-20s, she lost the canine and this has been replaced by an implant and she has a gummy smile. And if you want to see a little bit more, when I look at this picture, I have little sympathy for that. Because this should just simply not happen anymore. Because you have all the landmarks and we know all the protocols. I don't need a cone beam to see that there is no bone on the buccal of that implant. And you see, quite luckily, the papillary situation has not suffered too much. Huh? It's just the mid-facial, which is a huge problem. Can we fix it? Where are the periodontists in the field, in the room? Why can we not take a piece of connective tissue and put it on top of it? It will not work. It may occasionally work, but predictably, no. And you have to be really good. I saw tunnel techniques, and I will show you a little bit of that, what Professor Skoulian is doing now. But quite often when you try to cover this, and I could show you other cases, it gets worse. Okay, so there is no other solution for this patient, unfortunately, that removing this implant again. And it will not make a better site for a new implant, and you will have not a patient who is very, who is a fan of implant dentistry anymore. She will show her family, her friends, look what they have done to me. I got an implant here. And so that's why we hear also patients saying, oh, my neighbor had an implant, it's a catastrophe. So we have really to be careful. And I would like to show you, again, the key factors. Correct three-dimensional implant positioning, the right choice also of the dimension of the implant. This implant is clearly mislocated, and the importance of having a significant thickness of buccal bone at the end, because this will guarantee soft tissue stability. I show you an anecdotal example of a same location, a canine position, patient which we treated with Professor Buser, and this is already the 17 years follow-up. Of course, it's only a lucky anecdotal example, how well it can look. Look the smile of this patient. See, I mean, it's almost perfect, huh? And it's 17 years later. And that is what we know quite predictably we can achieve in any situation when we know which protocol to use. And here you see 21 years, and she will come this year to the 23-year control. We see her every year once. You see some evolution on the adjacent natural teeth, some recession, some cervical lesions, but the implant site is still as perfect as it was 20 years ago. So this is what implant dentistry can offer if we stick to the rules. Now you see here 11 examples of patients which had been treated with implants. I aligned them from the youngest to the oldest. These are single-tooth implants on the first row and adjacent implants on the bottom row. You see here the respective X-rays. And when you look quite critically at these pictures, because they all have acceptable restorations, that apparently you can achieve the goal with different implant designs and emergence profiles and so forth. So we still have to learn a lot what is really optimal. And when we look again without the X-rays, we have no problem as clinicians to identify on each picture where is the implant. Here we have a little problem because we could make two restorations. You have seen that before. But all the others is, this is the implant, this is the implant, this is the implant, this, and here we have the tooth. So what all these patients have in common, they have all been treated according to the early implant placement protocol with simultaneous contour augmentation. And there are decent results, and you cannot expect the same appearance when you're treating older patients, where already some evolution has taken place also in the adjacent dentition, and it just has to blend in as harmoniously as possible in the environment. Okay, so we know that is what should be the standard today. We can still do better. On my screen, it's looking a little nicer than on this one, but we know that this is what we should be able to achieve. When it comes to adjacent implants, and I'm not dwelling too long on that one, it is more complicated. We can try to work on soft tissue contouring as much as we want. Quite often we end up with this, and it looks not right. Why does it not look right? Because I was alluding to the line of emergence. Usually it should be triangular, and the most apical point of emergence should be distal to the long axis, and it shifts here to the mesial. And the technician, of course, did not want that black spaces are there, so he puts more white material and the balance is not there. And this is due to the fact that in the implant we do not keep a bone peak in most instances, and still today that's true. It needs, you can space more, you can use bone, platform switched implants, and I will show you examples, but don't promise the patient a perfect illusion when you have adjacent implants, because quite often it looks like that or worse. And if a patient says, well, I want that this is perfect, how can we do it? If a patient said, I want it balanced, what would be the option? We can do, of course, a 4-unit bridge on the 2 laterals, which today nobody would really like to do. And with 2 central pontics and a connective tissue graft, probably you could create the illusion of a perfectly scalloped soft tissue line, but the longevity would be limited to 15 to 20 years. You can then say, so what? Then once you lose that bridge, you can then place 2 implants in the lateral positions and repeat the procedures. Of course you can do that. And you could connect the 2 implants with the restoration and put some pink in center. That's something which we will debate also today. But we have to take a little bit more time to explain the patient who comes with 2 missing centrals and tell them, listen, we cannot predictably restore the appearance which you had on your photograph, which they bring with you to show you how it looked when they had their natural teeth. I don't want to overly stress that, but it is still a problem which is not completely solved today. We have procedures which are going in the right direction, but we have nothing that is really predictable. Okay, and now the bad news. Here you see 12 examples of aesthetic implant complications. As I said, my last section today will deal with this in detail, and we will show you these patients, how we treated them. You see, in the top row, the first implant, this is just an oversized implant placed too far to the buccal. This is a killer. We know that today. I remember the times when there was an implant type promoted where the tooth was extracted, scanned, and then a CAD/CAM device drilled an implant exactly copying this tooth and was put back. Because 20 years ago, one believed that the implant should be exactly like the tooth was. Today, we know that is not true. Use undersized implants, more located to the palate, and contour augmentation. So this is a mistake which should not happen anymore. The second one is a patient who got these implants when she was a teenager for congenitally missing teeth. And if it really gets dramatic, they start to disappear in the floor of the nose. Next one is a mislocated implant. This was a maxillofacial surgeon who had placed this too far to the buccal. And the next one is a single tooth implant, too apical, too far to the buccal. And the middle row are adjacent implants, quite dramatic, the one to the right here. And then the lower row is also just to rub it in. Adjacent implants are dangerous. Try to do the job with a minimal number of implants. When you have 3 missing teeth, don't place 3 implants. That everybody knows today. Use cantilevers, use pontics. And what you see on the bottom right is ridiculous. I'm wondering what was the treatment plan there. And the diamond which has been placed is not changing a lot. Huh? So, okay. There are complications which we can forgive and understand, and there are other complications which are just reflecting incompetence. And you know, sometimes people say, well, it would be interesting to discuss, everybody shows his failures. That is only a valid exercise if we are not including really the incompetent. Because even if we try to stick to the rules, things can happen. But some of these cases here is just really incompetence, nothing else. And we should not forget that probably the most frequent reason for implant complications is still us, not the environment or the situation of the patient. And I will try to come back to this. I don't want to get you depressed now, but we are preparing a book together with Danny Boozer, which we are publishing in 2016, and we have now, these are 12. I think we are presenting there 50 patients. So of course, they are referred to dental clinic, but when I talk to colleagues, many say, yes, I see more and more. Why do we see what you see here? What is one of the reasons? I try to convince you that single tooth implants are very predictable. I showed you many examples already, because they benefit from tissue support from the adjacent natural teeth. That is true. But what we also should not forget, that if something goes wrong, the single tooth implant in the anterior zone provides very, very little possibilities to correct. Tell me how you want to fix this. There's no way you can fix it. And we should not forget that. So if we have a preoperative analysis telling us we have very fragile, thin tissue, already tendency to recession, we should be extremely careful. What protocol we use? If you want to use an implant, quite often, you see, when I look at this today here, we probably could have made a bonded restorations from the canine and the cantilever, and probably had a beautiful result for a very long time. But now, nobody in the world can fix that. When you look at the distal of the central, you can graft whatever you want. It will not work. And what I see also more and more, what I call here desperate attempts to reestablish harmony. Of course, these are obviously two situations where we had recession, and then PINK is used. And what I would like to say is that PINK on single units is a no-go. If you do what you see on the left screen, that you embrace with the PINK the adjacent teeth, it may look, for a not too critical patient, quite okay, but you cannot clean that. And this will, on midterm already, create damage on the adjacent dentition. There is no doubt about that. If you do what you see on the right-hand screen, that is what I would call double papilla with a slot in the center. This can never look good, never. Just keep this in mind. What I appreciate that this clinician has used PINK composite. Sometimes this can help to create an optical illusion that there is still soft tissue if it's very nicely done. But what you see then on the implant restoration is ridiculous. I hope I can convince you. That's really... No. So that means that even single tooth replacement in the anterior maxilla needs a little bit of preoperative analysis to identify the dangerous situations. And then look, what protocol is the best, and do I eventually have an alternative? Also here, when you see on the canine with so little overbite, an ideal substrate for bonding, before just jumping into an implant and create a problem as you see here. Because what you see here is primarily due to the fact that the tooth has been lost and implant surgery has been performed. Okay. 25 more minutes. Current scientific documentation, clinical studies. We have now a growing body of literature. We saw this on the last consensus conference of the ITI, that now many publications on anterior implant protocols include a minimum of aesthetic parameters. That is a must. If you want to promote protocols of anterior implants, a minimum of aesthetic feedback should be there. It can be a questionnaire or patient interview with visual analog scales or indices, whatever. But I want to have at least one line saying the patient were happy also from an aesthetic point of view. Not only implant survival and eventually implant success. I would like to start with one publication which we did at the University of Bern. These were the first bone level implant prototypes we got, and then we were treating 20 consecutive patients which needed an anterior maxillary single tooth implant. All these implants had been placed by Professor Buser. We wanted to look if the hypothesis that we can keep the bone very close to the prosthodontic interface without creating bone remodeling or saucer is confirmed. And you see here one of the patients of that group of 20. And here you see another one. They still confirm the same phenomenon when you look at the implant shoulder. This was a patient which was already 55 years old. She already had recessions also on her adjacencies. You cannot expect the same. You just want something that blends nicely in the environment. That's all the patient is expecting from us. We were using pink and white aesthetic scores. And I'm not dwelling on that. There are different parameters today which are easy to use, which give us at least a superficial impression of how aesthetically performing the procedure is. And you see that we could reach more than 8 for both parameters. And the threshold of clinical acceptability had been set at 6. So that really shows that we can achieve that goal. And here you see all the 20 patients after 3 years. What, of course, the primary goal was to measure implant, bone to implant contact interproximally to confirm the principle of platform switching, but also to look if there are recessions occurring. And you see in none of these 20 patients recession has occurred, confirming the validity of this contour augmentation, which I mentioned before. When we look at the aesthetic scores, we see no change after 1 year and 3 years. Basically the same numbers. So that means, again, tissue stability. That's all we want. We took impressions on all these patients after 1 year, 3 years, 6 years, and we will do the next publication after 10 years. We are now at 8 years. And we have all these models of these patients. You see, this patient, that is photographed just how they come in. The first year she had poor oral hygiene, now she has improved. And we can do all these measurements also on the models now, not only on the implant crown and on the natural control tooth, but also on the adjacent dentition. This gives us a fantastic database of what is going to happen also in the environment. And you see here the deltas are very, very small. It means virtually no change over time. I'm really rubbing it in because all these patients, we waited after tooth loss for soft tissue healing, opening a flap, placing an implant a little bit more to the palate, contour augmentation, membrane, primary wound closure. And it's quite unique. The Journal of Dental Research accepted that we publish all the 20 X-rays. Usually you always see the nicest one in the publications. But there you have all of them. And you see that it has confirmed that we keep the bone very, very close to the prosthodontic interface. We have just one patient here where we lost some bone. But I could show you the X-ray already after 1 year. It was like this. And we were worried, but it does not continue. So 19 out of 20, we kept the bone within a few tenths of a millimeter interproximally with this protocol. But what is probably more significant, Professor Buser came with the idea, we will ask the ethical committee of the University of Bern if we can, after 6 years, perform a cone beam on all of these patients, which of course is an ethical problem because the patient will have zero benefit of that X-ray, and it's irradiation, which we know we should keep minimum whenever possible. But the committee said if the patient accepts to give written consent, would be the first time that we can prove or we can examine what is left from contour augmentation after 6 years. There is zero study so far before that study in the dental literature. I've seen 2 publications where they did some cone beams on immediate implants, and they had a huge percentage of zero bone on the buccal, and still no recessions because of the adjacent teeth. But long term, it is risky. So all these patients agreed to have this cone beam. We, of course, made only a window of 4 times 4 centimeters, not the whole head, so to keep the irradiation limited. And you see here all these patients after 6 years. I will come back to this later. These are the clinical pictures. And these are all the cone beams. This is unique material. This is all Professor Buser placed the implants, same protocol all the time. Are we happy with all these cone beams? Or is there one which one? M. And Buser looked at it and said, well, he looked at his surgical protocol, which he always writes, and he says, well, probably I placed the implant not sufficiently to the palate, but he did exactly the same. He covered the implant, the exposed implant surface with autogenous bone, and then bios on top and membrane. And you see this is gone. So far, it has not created an aesthetic problem because still it's a single tooth implant which benefits from adjacent teeth, but we are carefully observing that patient, and we would not be surprised if there, in the years to come, we will have an aesthetic problem. But all the others maintain. This is 6 years after the procedure. So that means this will probably stay for a long time. And we measured it at different vertical height, and you see we had 1 to 2 millimeters of bone thickness labial to the implants. That is unique. I hope that I can convince you that for the time being, this is the most predictable protocol when it comes to maintaining tissue stability. Now, the bad news. I know it's very small, and it's probably difficult to see here. You have the 20 patients represented after 1 year and after 6 years. And I placed them in the same location. And now we can compare. Just visually. Compare this implant here. After 1 year, the incisal edges were almost identical, and now we have this step here. Patient says, "Oh, yeah, I've seen it now, not a big problem so far." But others may say, "This disturbs me really." And we will come back to this in a second. Did you identify another patient? This one. We also got recession on the crown on the natural tooth. It's always the implant, which, because it's ankylosed, which will make the discrepancy apical. That means that the environment is still growing. That is what is most plausible. A third one, there are 20 patients, and we have 3 of those, which have created an incisal edge step. And these were all patients which were way beyond 20 years. One of these patients were 50 years old, and still we saw that. And a fourth problem here, you see, at 1 year, we had clearly interproximal contact, and now we have a small diastema. So things are happening around implants, and we know this also in the posterior part of the mouth. So, my dear colleagues, what do we do with that now? Knowing that this is the reality. In a certain percentage, we will see differences occurring. There is publication showing long-term growth of human beings. The orthodontists have quite some literature on that, because you can follow this on lateral Ceph X-rays. And we know that in maybe 8 to 10%, we will see this. What does that mean for us now when you have a young patient with a lost incisor maxilla? If you are extreme, you say we should not place implants in the anterior maxilla. That's really extreme. Because what would be alternative? Orthodontists say, well, I try to do it to close the spaces orthodontically. This is not realistic. When you think about all the accidents and endodontic failures, and each time want to implement either orthodontics or conventional prosthodontics. Okay, but it is sufficiently significant that we should inform the patient that the implant will probably stay for very long, but the restoration may need either modification or replacement 10, 15, 20 years down the road. That's no big problem, but as we discussed yesterday on the study club meeting, it calls for me for directly screw-retained restorations. If you want to modify, and I will show this afternoon, you need to have an easy access. Don't make 2-story buildings where the crown is cemented. Then you have to destroy. So inform the patient, do it anyway, and what would be a third conclusion, knowing that this is happening? Postpone implant placement where you can decently do it. And don't forget the potential of bonded restorations. Only attaching a missing tooth element to one side, not Maryland bridge attaching on both sides. They debond much easier. Just attach it to one side. If you have a possibility of doing it almost reversible, no preparing of the tooth, just bonding. That means good conditions with respect to overbite and overjet. Then look at it. Otherwise, place the implants. We wait. In my clinic, no implants are placed in the anterior maxilla before 20 years. This is not preventing completely this, but you will not get the dramatic situations. And we still do in Bern implants in the anterior maxilla. That's, I think, very important finding. Now I'm coming to the large section of clinical and laboratory procedures. Again, just showing you 12 patients which need some intervention in the anterior maxilla. And I will show you these patients during the day. This is the garden variety of aesthetic problems. We can see we have old infiltrated restorations, we have loss of soft tissue, more dramatic in the two central on the top row. Then we have erosion and attrition patients. Then we have congenitally missing teeth, old Maryland bridges, traumatized teeth, and then on the bottom row already implant therapy which was not successful from an aesthetic point of view. Do you also see patients like this? And they need some treatment. And I will now start to treat those patients. That's an old case, just showing what is the evolution of conventional restorations and what we have learned from that and implement now on implant. This was, I think, 17 years ago. Patient was sick and tired of having always these infiltrated restorations. This was before the area of efficient bonding. And you see her now on this stage. A slight gummy smile and heavily restored incisors, 4 of them already root canal treated. What do you expect? We are looking now 17 years back. What do you expect to see on the next picture? A close-up. You see that? Yes. And I just want to rub it in. Now the shocking picture will come. What do you expect to see? This should really affect all the young clinicians here in the audience. I see that you're mostly very young. That is what we have done, my generation, all the time. We thought this is perfect restorative dentistry, well executed and high quality. And if you have a good technician, then you can come up with a very nice result. But we have sacrificed a lot of substrate. And today, we have much more elegant tools in situations like this. This is just the last resort, if really. And there was, according to me, only one tooth which really would have justified this kind of treatment. All the others, we could have managed with restoration, with adhesive dentistry. What it shows how you can compensate with prosthodontic tricks. That means long interproximal contacts, a little bit more to the palate. Keep the transition line angles. Look at the light reflections here. On its original position, then the teeth do not look larger, although physically they are. But we have no open embrasures, and we have a certain degree of harmony. I hope you agree on that. So this is well-performed, traditional full crown prosthodontics. It still needs, we still teach this to students, but we tell them you will do probably very, very few of those. Because most of it, we can do it in a more elegant way. But we learned how to compensate loss of tissue. And we implement this, that is interproximal contour and positioning of the transition line angles. That is the key, which we need all the time when we are restoring implants, because we have always a lack of soft tissue. Now this one, that's an interesting one, just before the coffee break. What is your diagnosis when you see a thing like that? You ask the patient, and then she says, yeah, I had trauma. Yes, this tooth was out of my mouth, has been re-implanted, and then it got shorter and shorter, and my dentist has added acrylic. And now we see advanced signs of resorption, and we know we cannot keep that ankylosed tooth. And we have a dramatically irregular soft tissue line. And we have healthy adjacent teeth. Okay, and we want to create the perfect illusion at the end. And we were debating with Professor Buser, what shall we do? And then he said, well, you remember the publication of Burton Langer. He's a famous periodontist from New York. We should give room for soft tissue before we remove that tooth. And so what I did is I just went, I of course took an Algident impression first to have a removable provisional denture in my hands when I did that. Patient agreed. I removed as much as possible just to give room for keratinized soft tissue to occupy that room. And that is how the patient went home at the end of that session. Of course, looks ugly, but she was well prepared and informed, and she accepted. She comes back 2 weeks later. Already, you see, tissue has occupied logically because there is no tooth structure there, and we decided that I removed a little bit more. And here you see on the right-hand screen the patient another 2 weeks later. And then Professor Buser made a very small flap without elevating the papilla, and he splits it orofacially. You know, we are always think we should be very careful on the buccal bone plate. Buser says the only bone plate which is very important for me is the palatal one. That's the most important, and interproximal. The buccal, I will anyway do contour augmentation when I place the implant. So that is how he creates his slot, and then he comes with an elevator and fracture and removes it without another thing. And then he places here just collagen in that site and primary wound closure. And here you see the patient 10 days later, nicely healed. So we take the sutures off. And 3 months later, he places a bone level implant. And this is at the moment where we can insert the temporary restoration. You see, of course, this is the picture immediately after having placed, removed the root, then placing the implant, and this is now the X-ray with the temporary restoration. Looks nice, huh? Looks nice. Is this a miracle or is it logic? Look now. That is where we started. This is the first step, and this is now at the end of the temporary phase. Why was this happening so well? This is just normal. We had no tissue loss at all interproximally. See the papilla, it's like a Miller class 1. We created the room. I doubt today if we not eventually would have achieved the same goal with removing the tooth immediately. Probably we would get the same thing. But it was an elegant thing. We had an additional safety that we compensated already a little bit of the irregularity by creating this room, and then it was just logical performance of surgery, placing a smaller implant a little bit more to the palate, and no trauma of that site, and then you will get it. You agree on that? Do that. I will show you after the coffee break this one. Exactly the same. And asking you, is it really the same? We will see this after the break. Now we make 30 minutes coffee break.